All right, it is 10 o'clock, so we will go ahead and get started. I know that people are commenting right now they don't hear any volume. Now you should, now that we have some people talking. But welcome to Miranda and Amanda's presentation on dementia this morning. We are looking forward to it. My name is Danielle Daly. I'm the Professional Development Coordinator here with the Illinois Crisis Prevention Network. I'm just going to go over a few housekeeping things, and then I will pass on off to Miranda and Amanda. Everyone is muted. Your cameras are disabled. Please use that chat box throughout the presentation to interact, to ask questions. You can also use that Q&A to ask questions. Please make sure that your settings are set to everyone. I think automatically it pulls up just hosts and panelists. So make sure that it's set to everyone so that everyone can see your comments and interact throughout the presentation. Please visit our website, icpn.org. We do not have any future webinars posted at the moment. There will be some new ones added within the next week and a half. So please be sure to check those out. If you are on our mailing list, you will also receive information about that. If you are not on our mailing list, if you go to our website on the top right-hand corner, you can click join mailing list, type in your information, and then you'll be added. So you'll have that firsthand knowledge of all of our webinars and other exciting things. Continuing education certificates. If you actually were in our webinar a couple weeks ago, I am trying to finish those continuing education certificates up today. I'm hoping to have the rest of them out this afternoon, and then give me about 14 days to get these CEs out to everyone. I apologize. There was a little bit of a delay. We had our annual conference last week. Thank you for all who attended. But I'm a little bit behind, but please give me about 14 days. If for some reason you do not receive your certificate, then please reach out to me after that 14-day period. I will put my email into the chat box so that you have that. I did send out the presentation and handout to everyone this morning. I did get a few kickbacks. So if for some reason you did not receive that this morning, first check your spam, because I know that my emails sometimes go to everyone's spam box. And then shoot me a quick email. I can send that off to you as quickly as possible, or I can send it with your certificate as well. I think that that's it for me. Miranda and Amanda, if you want to take it away.
All right. Thank you, Danielle. Well, welcome everyone to When is it Dementia? Determining Normal Aging versus Disease in Seniors with Intellectual and Developmental Disabilities. Okay, loves to do this to me every time. There it goes. Perfect. So my name is Amanda Ripley, and I'm a board certified behavior analyst, and I will be presenting today with Dr. Miranda Traha. We have been clinicians for challenging behaviors and dementia since the early 2000s. We have practiced in Michigan, Colorado, Florida, Illinois, Maryland, just to name a few. We have worked with several different diagnoses related to dementia and aging. And then we have also coordinated with teams in family homes, nursing homes, group homes, day program, adult daycare services. If there's been a senior and there's been a challenging behavior, we have provided a service there. You can find out more at abilities.today. On this screen, you can see the handouts. This is what Danielle was referring to earlier, just a couple seconds ago. So there's a couple of sheets that you'll be sent out that will, just kind of highlight some of the things that we'll talk about today. A good place to take notes or just kind of pull some of that more specific information. Okay, so again, welcome. This is a toolkit for basic information about dementia. In this course, you will learn about the vocabulary that we are using in the geriatric community. We'll discuss statistics, symptomology, screening, end-of-life issues, really a range of topics that all practitioners need to know before working with dementia. And no better word to start with than the word dementia itself. So dementia is actually not even the term that scientists, researchers, and some physicians are using anymore. Per the DSM-5, dementia is technically neurocognitive disorders, or NCD. And NCD is any disease related to decreased mental function due to disease or illness. And in this course, we chose to use the word dementia instead of NCD because in clinical practice, it's the most frequently heard term in the majority of interactions that we have. NCD is also a bit of a mouthful to say every single time, neurocognitive disorders, and most people honestly just don't use it in their everyday vocabulary. So for simplicity purposes, when we discuss dementia today, we are talking about the DSM terms, neurocognitive disorders, but we will use the term dementia. So in this next section, we will review the different types of dementia. So dementia, as you can see, is an umbrella term for several different types of dementia. The most common ones that you probably have heard of is Alzheimer's disease, vascular dementia, Parkinson's disease, Lewy body dementia, and substance abuse-related dementias. The ones that we work with in clinical practice are irreversible conditions. For these individuals, their brains cannot get better, quote unquote. There are some dementias, though, that are reversible, but none that we are specifically going to talk about today. There are, in fact, over 70 different types of dementias, and here's a list of several of them. So we won't discuss those more rare dementias, but we wanted you to know that there are a variety of reasons why someone can have a memory problem. So let's dive into the types and causes of dementia that are most common in our clinical practice. So let's start with Alzheimer's disease. The suspected cause of Alzheimer's disease is amyloid plaques and tau tangles. Both are proteins. Both are classic biological hallmarks of the disease or biomarkers. Beta amyloid plaques, you're going to find those outside of the cell structure, and they are abnormal clumps of protein built up in the spaces between brain cells. Now, tau tangles are inside of the cell structure, and these are also abnormal protein buildups around the nucleus and inside of those cell walls. Now, research does not know exactly what that relationship is between those two proteins, but that's what we're seeing on those brain scans and all, post-mortem research and whatnot. At a closer look, you can see healthy cells in the lower right-hand corner. Synapses are free to communicate with each other. Those are the legs that shoot out from those cell bodies. Now look at Alzheimer's disease, which is that bigger picture on the slide. There are big balls of amyloid plaque right outside of those cells. These balls of protein are in the way, and the cells cannot send messages to one another. Unfortunately, we do not know much about the relationship cells have with this plaque. Like, does their presence flag another separate process that causes dementia, or is their absolute presence of these proteins cause the dementia itself? All we know is that these proteins build up over time, cause difficulties for the cells to communicate with each other, and the phenotype expression or the clinical symptoms look like how we define dementia. So with Alzheimer's disease, the amyloid plaques grow in the middle of the brain, in the hippocampus area, which affects emotion first and then memory. Then the plaque grows into the various brain cortexes, and this affects speaking and understanding. And then eventually the entire brain is covered with amyloid plaques. And this is going to affect everyday skills and functioning. Things like eating, sleeping, thinking, remembering, sequencing, orientation, perception, really everything. Then in the end, a brain shrinks and nerves die everywhere. And we call that brain atrophy. The person becomes more of a respondent being and continues to decline until limited stimuli can elicit or evoke responding. So when we discuss the stages of decline or the progression of decline, there are some minor differences in the progression of decline depending on the differential diagnosis. So let's say this decline is gray for normal aging. no dementia, no memory issues. The person lives to be, near 100 or past 100 years old. Yay, good for them, right? So research shows so that around the age of 40, everyone's body declines, dementia or no dementia. It's a biological effect that's happening at the cellular level. Now we know our baseline of basic human decline. Let's compare that to specific types of dementia to this natural, normal human decline. So if you were to map out the progression of Alzheimer's disease in purple, you would see a gradual and continual decline. Note that the decline is steeper and faster than what you see in gray, which is that normal aging. There are stages of decline in Alzheimer's, and they will follow a near linear decline in overall functioning. Let's take a look at what that looks like. So no one fits into a predetermined stage, not specifically, right? But there are 5 general stages that people fall into. So let's say that a person is in a state of decline that is undetectable using our screening tools. So it's this state where other people may notice changes or other people may even think that there's something wrong with their memory, but the person scores high enough on those memory tests. Well, that means they're in that pre-diagnosis phase, a phase where we have an inkling that something's going on, that something's a little different, but the tests that we have aren't strong enough to detect those memory problems. And then there's the mild, moderate, severe, and late stages of decline. And as you can see with this Alzheimer's disease, it's a fairly gradual and continual decline over time. So let's turn our attention to vascular dementia now. While Alzheimer's disease is caused by plaques and tangles, vascular dementia is caused by problems in the supply of blood to brains, to brains, oh my gosh, to the brain cells due to conditions like coronary heart disease, high blood pressure, irregular heart rhythms, high cholesterol, diabetes, peripheral artery disease. If a person had high blood pressure or a stroke, and the blood flow is temporarily blocked to an area of the brain, like a blood clot in the middle of an artery, which is what you see on the slide there, there may be a brain bleed. So scar tissue builds up around that area to stop that bleeding. Now, the scar tissue basically acts as a roadblock to the cells around it, right? So the cells can't communicate in the same way as before. This acts similarly to how those plaques and tangles work for Alzheimer's disease to block that cell communication. So this brain damage may be minor if the person only had one small stroke, but people with vascular dementia have frequent mini strokes. So for example, like on the screen, on the slide B, there are many mini brain bleeds, and that's where those arrows are pointing right there on the screen. And then of course on slide A, that would be, a healthy brain. So these represent the blocked passages of neurons. These blockages create a decline in cognitive function, and that leads to dementia. A person may not even know they're having mini strokes until it's too late and the damage has already been caused. So if the progression of Alzheimer's disease is gradual and linear, which is what we saw in purple, right? The progression of vascular dementia is more like a staircase, and that's what you see in blue. There will be a decreased ability right after the first set of mini strokes, then stability in skills over a period of time. And that can be honestly sometimes even years. And then after a series of additional mini strokes, and sometimes this can even occur while someone is sleeping, then there is another significant decline in those skills. In practice, when staff and families say, gosh, there's been a major decline this week, or sometimes it's even that like last night they went to bed and then this morning they woke up and there was a significant decline in skills, it's usually acute and sudden. These are the clinical signs of vascular dementia, what we see in everyday practice. Interestingly enough, we're seeing more mixed dementia too, which is a combination of Alzheimer's and vascular dementia. And that can happen with our intellectual and disability clients too, mixed dementia and a mixed pattern of that decline. So mixed dementia is 2 or more of any type of dementia. It could be Alzheimer's disease and vascular dementia, so the person gets a mixed dementia diagnosis. It can be vascular dementia and substance abuse dementia. It can be Alzheimer's disease, vascular dementia, and Lewy body dementia. So mixed dementia can be 3 dementias, but it at least has to be 2. So as clinicians, we do think less about those types of dementia and more about the symptoms. We need to be aware of the differences in these diagnoses because the symptoms, because they're a little bit different and that decline trajectory is a little bit different, they can help us to decide which life skills to target first. So no matter the type of dementia, really there's not a specific cure. You can't take a pill, it's not going to go away like that. There's not for Alzheimer's disease, vascular dementia, Parkinson's disease, or frontotemporal dementia. There are things that you can do to help those brain pathways to become stronger, and there's medications on the market to manage those symptoms. And we'll touch upon that a little bit later in this course. But at the moment, there really is no cure. So families and staff need solutions today to manage those symptoms. And that's why you're here, stepping up to work with this population. So let's talk about those risk factors, symptoms, and dementia within the IDDD population. So for the general population, the risk of dementia is about 4% by the time a person is age 65. And this risk doubles every 5 years, so that by the time a person is 85 years old, there's a 45% risk of dementia. For individuals with intellectual and developmental disabilities, the risks double and increase over time. It's just that way. It's just that we see that their diagnosis is a little bit earlier in life than we see for the general population. So what are the risk factors? So what you see in purple, those are primary risk factors. Primary risk factors include the age of an individual and family history. However, just because a family member has dementia, it doesn't guarantee another family member's diagnosis. Another primary risk factor is brain trauma. How many hits to the head has a person had? The more hits, like doing sports, soccer, baseball, football, car accidents, assaults, violence, any sort of difficult falls, the more insults to a brain, the greater risk of a memory problem later in life. Another primary risk factor is Down syndrome. Down syndrome is another primary risk factor for dementia, specifically Alzheimer's disease. The prevalence for individuals with Down syndrome is a little different than the general population. So 5% by the time a person with Down syndrome hits the age of 40, and 45% by the time a person with Down syndrome is between the ages of 56 and 60. The course of the disease appears to be about the same with Down syndrome. It's just a lot younger when a person is diagnosed or during their decline. Something interesting about Down syndrome is that third chromosome that they have for chromosome number 21, that's the same exact chromosome that makes amyloid plaque in the brain. So their brains are making more plaque faster than the average brain. And that's why it's great for people with Down syndrome to be a part of Alzheimer's research. They're a population we know is going to get, or there's very high comorbidity rates with Down syndrome and Alzheimer's disease. So if you know a person with Down syndrome, encourage them to be a part of research or do a drug study in your area. Now, in yellow greenish at the bottom, those are secondary risk factors, and those are education, high blood pressure, diabetes, smoking, poor sleep, etc. So just because you're well educated, you exercise, you consume your proper nutrition, you're eating your fruits and vegetables, that doesn't prevent the syndrome altogether. It may decrease those risk factors, but it doesn't prevent it altogether because you still need to consider those primary risk factors, the ones we talked about in purple. So what is dementia? Dementia is a syndrome, a collection of signs and symptoms. A sign is objective, something that you can see. So things like rash or unsteady gait. So, and a symptom would be something that's more subjective, something you cannot actually see. So when someone has a hallucination, or if there's difficulty thinking, right? They might express that back to us, but we certainly can't see inside their brain to know that they're having difficulty thinking. So dementia will include signs or symptoms of two or more of the following: memory loss, impaired judgment or abstract thinking, loss of communication and language skills, disorientation to time and place, gait, motor, or balance problems, inappropriate or challenging behavior, and then neglect of personal care and safety. Remember this graphic from earlier? As we said, no one fits exactly into a predetermined stage, but this is generally the progression of dementia. And we wanted to show the decline in multiple ways. So here's the dementia decline in terms of years. So there's that pre-diagnosis phase, and that's going to last approximately 10 to 20 years before diagnosis. And then we have the mild, moderate, severe, and late stages of dementia. And those stages are each going to last approximately between 2 and 4 years. Now, this dementia decline would be the same for individuals with intellectual and developmental disabilities, especially within that mild range. For someone with Down syndrome or severe and profound intellectual and developmental disabilities, the dementia decline will go much quicker. So we'll still have that 10, 20 years for pre-diagnosis, but then 1 to 2 years during that mild, moderate, severe, and late stages of dementia. During those pre-diagnosis and mild phases of dementia, there will be a loss of instrumental activities of daily living, so the IADLs. And during the moderate to late stages of dementia, there will be a decline in activities of daily living, so the ADLs. So the instrumental activities of daily living, the IADLs, are self-care tasks that we typically learn as teenagers. They require more complex thinking skills and include organizational skills. Things like driving, managing finances, grocery prep, meal prep, coming up with all the ingredients that we need to make a meal, medication management, housekeeping, chores, using the phone, all those sorts of things. And then activities of daily living, those are the basic care tasks that we usually learn when we're younger children. So activities like the dressing, bathing, grooming, continence, feeding, eating, ambulation, walking around, and transferring. Aging services is not like children's services or honestly even adult services where the goal is for the person to be as independent as possible. We are always planning for decline when we're working with an aging senior. We are planning for how can the caregiver prolong independent behaviors and decrease those challenging behaviors. There is almost always a component of caregiver training. And with this within this caregiver training, the reason why that's always a component is because there's going to be a level of care that is always going to need, this person is always going to need a caregiver to help support them throughout their decline. For a neurotypical person with dementia, there are several steps that you can take to get a diagnosis of dementia, or even a differential diagnosis of which type of dementia. That process is usually you get a cognitive screening tool. So this is usually a 30-minute question, or not 30-minute, sorry, a 30-question test. It could be 30 minutes, who knows, given by the primary care or the memory doctor. Sometimes the primary care physician or the neurologist may recommend a battery of tests, and these are more thorough neurocognitive tests. This would be, more like a 2 to 4 hour test to rule out dementia and help give a differential diagnosis. Additionally, a person may have their brain scanned to check for those amyloid plaques or to look for those mini strokes. That's what we talked about earlier. Now, we're not going to go through each one of those types of brain images today, but you know that a neurotypical person with suspected dementia has several different options when it comes to testing. The process is very different for a person with an intellectual and developmental disability. In fact, they only have access to one of these testing options. And it's not surprising, it's the least scientific one because they're only descriptive assessments. But it is the most scientific one that we can do because at least it's going to help us and direct us into what is going on with this person. So even with all that said, know that in the end, there is no difference between the diagnosis or symptomology between the general and the IDDD populations. The differences are in those screening tools and the clinical examples tailored to our intellectual and developmental disability folks. And we're going to show you a few of those. So the first screening tool we wanted to show you was the Adaptive Behavior Dementia Questionnaire, or the ABDQ. You can find this online easy peasy by Googling ABDQ or the Adaptive Behavior Dementia Questionnaire. So this questionnaire is great to use for individuals with IDDD because each of the question is asking about how the person is behaving now to compare to what they were like years ago. So the other type of screening tools, ones that you've probably heard of before, so the MMSE or the Mini Mental Status Exam or the MoCA, which is the Montreal Cognitive Assessment, those are asking standardized questions that an individual with an intellectual and developmental disability might already not know, thus giving them a misleading lower score. So this screening tool, the ABDQ, looks at different areas of a person's life, like bathing, dressing, memory, behavior, comparing their skill set now to what they used to be able to do. And we recommend providing this questionnaire to a staff or caregiver that has known the person for a longer period of time and works with them during everyday type of interactions like eating, dressing, bathing. The person being interviewed needs to have specific knowledge of a person's skill set. So a QIDP or an admin staff that is involved, but not assisting in these types of everyday kind of activities could provide the assessment, but shouldn't be the people that answer those questions. It really needs to be kind of a staff boots on the ground person. And at the end, there is a method of scoring that determines the likelihood of dementia. So you kind of see that, kind of over 78 or under 78, and then the severity of the dementia, which I think is pretty helpful in terms of, just kind of guiding a team and guiding even the diagnosis and whatnot. The next screening tool we recommend for individuals with IDDD is the NTG, the Early Detection Screen Tool for Dementia. This tool also compares a person's current skill set to what they used to be able to do in a variety of areas, like activities of daily living, behavior, memory, but it also asks some pretty important questions about placement, transitions, medical and psychiatric issues, and trauma, which could all play a role in treatment and determining if the causes for those changes is actually dementia. So the thing about this one, though, is that there is not a score at the end of this screening tool, but it provides very thorough and robust information so that a doctor can more effectively diagnose dementia or pursue other medical rule-outs. So we recommend that the ABDQ and the NTG be completed annually for a person with IDDD, starting in their later 50s. And for Down syndrome would be maybe in their 40s even. By having this documentation early and completing it annually, this will provide a better data set for those doctors to diagnose so that they can see those change in answers over time, year after year. So you probably start at, when someone's not showing in those pre-diagnosis stages, right? Or that pre-diagnosis stage, you're going to start it way early and it's going to not show anything for years and years and years. And then it might, well, hopefully not, but it might show changes as a person ages. And then you'll have all that information to present to the doctor. Okay. It's the National Task Group. Sorry, the NTG stands for National Task Group. That's what that acronym is for. Thanks, Amanda.
All right. We had several questions if you're okay with taking a couple of them now.
Yes, let's do it.
Okay, so Nancy asks, how would we notice the mini strokes? Don't strokes need to be treated to avoid someone continuing to bleed internally?
Yes. So if you did notice, if you think that a person is having a massive stroke, absolutely. You got to get them in. There's some medications that need to be given to them immediately. What Amanda was referring to is sometimes a person is not having a massive stroke, they're having these little mini strokes. And um the older that they get, the more risks that they have, and sometimes you can't even honestly tell that the person is having a stroke or had a stroke, one of these little mini strokes. Sometimes it looks very similar to maybe even a person having I forgot the type of seizure, but they're just kind of looking away.
An
What's
absent
that?
seizure.
Thank you. And it's just this moment where they're not with you, they're not very lucid. And usually it comes after you've already had a diagnosis of vascular dementia, or you know that the person has heart conditions, like Amanda mentioned, the congestive heart failure. And this is not something that we come up with. What the plan is going to be in place when you notice a mini stroke or a massive stroke, that comes from the medical doctors or the medical team that we're a part of. Because what we don't want to do is take them to the hospital every single time there's a medical issue going on, unless that's what the doctor prescribes. But often you'll see in end of life care, it's more like, what can we do to make them comfortable while they're having some kind of medical episode? So the care team will put in place, here's what we're going to do. Here's when we go to the hospital. Here's when we don't. Here's when you contact someone from the team. And maybe it's just a phone call and letting them know what goes on. Anything else to that, Amanda?
Mm-mm.
Okay. Let's see. April asked if dementia was similar to white matter disease.
So I have heard of, I don't know if it's the exact same thing, but what happens is as the brain atrophies, white matter grows, which means that it's not like an active part of your brain. So the inactive parts of your brain are growing. And so maybe like when you're reading a CT scan, that's just a black and white image. So sometimes people will refer to white matter or gray matter in terms of looking at scans, but I'm not exactly sure. I would imagine that it goes in that umbrella term of different types of dementia. Clinically, in practice, when I'm talking with doctors, they don't usually refer to it as white matter dementia. Would you agree,
Yeah,
Amanda?
I
Yeah.
agree.
At what age do we typically start seeing decline in cognitive functioning of individuals with Down syndrome?
I mean, it can be early. I mean, that's why, we recommend starting to do those annual assessments at age 40 for someone with Down syndrome, because it's going to be, a couple decades sooner than a neurotypical person or someone with mild ID. So, I mean, I mean, 40s, 50s.
Definitely. And just like how she showed on the graph that, in that pre-diagnosis phase, they can have symptoms for 10, 20 years. So they can be at age 30 and engage in a behavior that they forgot something. And, oh, Lucy doesn't usually forget that. That's strange. And so we can either say, oh, it's typical aging, or maybe she had a memory moment, or maybe, something else in the environment. We just, honestly, we do not know when they're that young. We know that they're at a higher risk, and that could possibly be an early symptom of dementia, but we won't know until, the amyloid plaque grows more and we can make a more definitive diagnosis. But again, like Amanda said, testing early, often, is going to be your best bet, because especially in the IDD population, we have to rule out all these other things. And so if you have a nice annual assessment of their memory, then we can start ruling out some things and maybe even lead to that diagnosis of a memory problem.
And Kelly asked, even if it's someone in their 60s, can it be something that happens like overnight, like where they're forgetting to how to dress or how to eat, and it seems to happen overnight versus, gradually?
I guess it would probably depend on the type. And I would, if something like that were to happen before I jumped to a dementia conclusion, I would rule out medical. Like, does this person have a UTI? And Marina's going to talk about this a little next. But before we can even go to dementia, we're going to rule out, are the medications influencing. If this person's lost any weight, then medications can be too robust, just too high of a dosage. We're going to rule out other psychiatric issues for memory and cognitive impairment. We're going to rule out UTI or other infections or disease before that, before you jump to dementia. So before I would think it would happen overnight. I mean, it doesn't usually quite look exactly like that. I guess it could, but mostly there'll be smaller signs that maybe staff just aren't picking up on, which Miranda will talk about in a second too, just the serious importance of documentation and communication between teams so that you can pick up on those small nuances.
Can you repeat
Yes.
the three screenings that you discussed?
So it's just two. So it's the ABDQ, the Adaptive Behavior Dementia Questionnaire. So the Adaptive Behavior Dementia Questionnaire, and the NTG, which is the National Task Group, but it's their early detection screening tool.
And someone had asked the protocol for providing those, whether they should be done annually by physicians or if other team members can administer those.
It should be the team. So I, as the behavior analyst, I've done it through SST. I've also done it. A Q would be a good person to complete it while interviewing a staff. So the Q really shouldn't answer the questions themselves. It should be asking those veteran staff that work day in, day out with an individual, and preferably someone that's been there maybe a few years so that they can kind of compare to before and now. Nurses, the nurse on staff with that agency, any of those people. So it's not really, it's information you bring to the doctor, not information the doctor would ask you. They probably won't even know about those dementia questionnaires. Lots of providers that we work with don't know what to do with our individuals, that they kind of say, well, we don't know if it's dementia, we can't tell. And none of the insurances will provide, won't cover for our individuals. The waiver programs won't cover for any of those scans. And so then they kind of just leave us in limbo. But those questionnaires really help us, and we can give that information to the doctor so that, and all the other information too that we've ruled out, so that we're kind of just left with, well, it can't be anything else. It has to be dementia.
And just to piggyback on that, we're already doing annual or semi-annual assessments. So it's easy enough to add one or both of these assessments to your list of things that you're documenting on our individuals, and to keep in their case file so you can have a nice baseline of their memory.
There are still a lot of questions, so I will keep track of those and see if we can touch on them at the end, because I don't want to take away from your presentation. The last thing I do want to ask, we've had a couple people ask about like something like medication and self-injurious behavior. Does that have any impact or risk of dementia?
Like if the more medication that they're taking?
Yeah, if like certain medications have long-term impacts.
Only thing that I've read in the literature that's coming out, you'll see it's really getting at those secondary risk factors that Amanda had mentioned. So things like what you're eating, how much you're sleeping, that could potentially increase your risk factors. I do know that I forget what the class of medication is, but it's kind of like Benadryls and antihistamine medications. If you take that consistently every day for years, decades, that can have an impact on your memory. But I haven't heard anything about, I would imagine if they're SIB hitting the head, that's insults to the brain. it might be little, or if they're tapping, maybe not so much, but if it's really hard, I would imagine that could impact their memory. I haven't seen any data or research. It's just a clinical assumption that I'm making. Well, thank you so much for those questions, Danielle. And so I'm going to go ahead and pick up where Amanda left off in the presentation. And maybe some of what I say next is actually going to answer some of the questions that y'all have out there. And if not, we'll have some time at the end to take your questions and maybe even get into insurance a little bit. Okay, so let's talk about symptomology. And what I want to go through is there's several different symptoms. And like Amanda said, the symptoms aren't different in the IDD population. It just looks clinically slightly different. So what the behaviors might look like in a neurotypical senior with NCD or dementia is going to be in blue. And then I'll go over what that same symptom might look like in a person with intellectual disabilities, whether they have mild cognitive impairment or if they have severe and profound cognitive impairment. And in that handout that Danielle's going to send out to you, we have a list of all the symptoms and an example for people with neurotypical dementia and IDD and dementia. So we're not going to go through all of them for time's sake, but I will go through a couple of these to give you an example. If we're talking about challenges in planning and problem solving, well, if a person has dementia of the mild type, then maybe they're getting lost while driving home. You know, they usually know the route to the grocery store and back home, or from the doctor's office and back home, but now they've gotten lost, and not just lost by a block or two, but they're lost for hours. Well, that could be a symptom of a memory problem. If they have later stages of dementia, then that major NCD, then the challenges in planning and problem solving might look like that they're putting on dirty clothes from the hamper. So instead of going to the closet to pick out the clothes, they want the same outfit that they wore yesterday, and they go into the dirty clothes to put that on. If a person has intellectual disability, say they have mild IDD, maybe they get lost walking home from the neighborhood gas station. And this is a gas station that's only a couple blocks away, and they go there almost every day, certainly several times a week. They've never gotten lost. You have total trust and confidence. You know, it's in their plan that they have alone time that they can go walk there and come back. But maybe one day or a couple times in a month, they're starting to get lost. They take a little bit longer to get home. They can't remember, do I turn right? Do I go straight? Do I turn left? That could be an early symptom for a person with mild IDD. And then say a person has severe intellectual developmental disabilities, maybe that symptom looks like they can't sign food anymore. And that was a consistent sign that the person can make all throughout their life, but now they're not touching, you know, right below their mouth. Maybe, you know, the hand is going in different places, or maybe they're not even bringing the hand up to their face. That could be a symptom of challenges in planning and problem solving. When we look at withdrawal from work or social programs in mild NCD, maybe that person doesn't want to attend larger family gatherings. So like Amanda mentioned earlier, some of the first clinical signs of dementia is not just that they forget things, but that they have a decline or a change in their emotions and personality. And we see that in attending family gatherings or social gatherings, and that maybe they don't want to go as much, even though this is a very preferred activity for them. In major NCD, maybe the person is actually just spending more time at home alone. They don't want to go out into the community, maybe even at all. For people with intellectual disabilities, this symptom looks very similar, but maybe slightly different in that in the mild stage, maybe they're quitting a social program like a church group where they consistently go every weekend, but now maybe once a month, or maybe it's starting to increase from there twice a month, they're refusing to go. And on the severe IDD side, maybe it looks like they're refusing to go to work or not attend these same holiday parties. Whereas again, they used to really love to go to these things. They were very interested. Even if they weren't dancing on the dance floor, they like to be a part of it and just watch. But now they don't even want to go anymore. Let's take the symptom of memory loss that disrupts daily life. So maybe in the mild NCD, it's that the person forgets steps on a childhood recipe. So they've been cooking this recipe all their life. They don't even need to follow a recipe anymore. And now they're starting to forget an ingredient or a whole step in the recipe. In major NCD, maybe that's getting lost in their own home. So they're walking around their home and they're saying, where's my bedroom? Where's the kitchen? Where's the bathroom? Or maybe they're even saying, this is not my home. Get me out. I need to go home, when they're actually in their own space. For the individuals with intellectual and developmental disabilities, if they have mild cognitive impairment, maybe they forget where things are kept in the house. So where do we keep all the toothpaste? And they're looking in the kitchen for it. Or maybe even they or looking for things that belong in the kitchen, in the bathroom, or in their own room. For severe intellectual disabilities, maybe they don't remember a close friend or a family member who comes to visit them quite often. And, they do recognize them when they were younger. But now when the person comes in, maybe they're just kind of apathetic. They don't light up. They don't glow like they used to when that person walks in. That would to us be some red flags that we want to check out, some memory issues. And the last one is if they have trouble with visual or spatial reasoning. So in the mild stage of NCD for neurotypical seniors, that could be that they miss steps, like in their home. If they're walking down the stairs, they might skip that last step, or when they're walking up the stairs, they might accidentally skip that last step, and they might have a slip or trip there. In major NCD, we just see an increase in falls overall for that population. For individuals with intellectual disabilities, the symptom of trouble with visual or spatial reasoning might look like, for mild cognitive impairment, they might be doing like piecemeal work at a day program where they're just kind of putting objects together, and they can usually put them together pretty easily. And as they decline, or one of the earlier symptoms is that they can't actually put it right together. Maybe it starts going like this, or they're putting the wrong piece to the pieces that need to be attached together, whereas before it was very easy for them to do. And then in the severe stage of IDD, you probably will see them bumping into doors or corners, countertops a bit more. They don't realize that their body needs to go, 2 feet around, and they're coming real close to the counter. You might see some bruising on their arms, elbows, or even on their hips from bumping in the doors as much. One big thing that we always have to do, always, is think and rule out delirium. So there was a question that came in that said, what if there's a sudden change in a person's behavior or memory? And Amanda kind of alluded to this, that, well, I probably wouldn't think dementia, because dementia is more likely to be slow and progressive. If it's acute, if it happens overnight, it's sudden, hours, days, there's confusion, some dramatic changes in that person's behavior, well, then I would actually think delirium, that the person is in a medical state of what's the word? Homeostasis, that is it's dysregulated. Their body is dysregulated. The good news about delirium is that it is temporary and it is reversible if we can treat it. If we don't, then we're going to have some long-term side effects that happen. So what is delirium? Well, we created this anagram to help out, to help you remember all the ways in which a person can have delirium. Because it can be produced in a client in a variety of ways. So the first way is diet. If a person has poor nutrition, they can be at a risk for delirium. Sometimes with our clients, we see that they're eating the same foods over and over, and this can actually have some adverse outcomes in memory and mood. So if we restore that balance, many of the nutrients that lead to delirium will be there will be a resolution, because they're getting some different nutrients, so the delirium will go away. The next one is electrolyte imbalance. That can definitely cause delirium. So an electrolyte imbalance happens when you lose a large amount of bodily fluids in a short period of time. So think about you're sweating way too much because you're outside and it's very hot, or you're sick and you're vomiting a lot. Now you're causing this electrolyte imbalance. Some of the seniors that we serve, dehydration is a major cause of electrolyte imbalance. So seniors might not recognize that they're thirsty and they drink less fluids, or maybe caregivers don't want to give as many fluids. You know why? Because we got to take them to the bathroom more often. So we want to stress that it is essential that we keep our clients hydrated, because the adverse events related to dehydration can cause so many more problems than going to the bathroom more often. So drinking water is often a protocol that we implement with many of our clients. The next one is liver, lung, kidney, or heart failure. Unfortunately, organ failure is actually a common comorbidity within our clients and can lead to delirium. Infections, kidney and bladder infections, as well as urinary tract infections, are really common in common cause for delirium in seniors. So UTIs can be overlooked and they can go untreated for a long period of time. And this delay in treatment can cause some behavior and psychological symptoms that sometimes people call us in to help to manage, like agitation, withdrawal, changes in sleep. But before we talk with families or staff members, we ask them to get a medical professional to rule out UTIs before we come in to do an assessment or intervention. R is for prescription drugs. It is not uncommon to see our clients on 10, 15, or even 20 prescriptions, medications, or supplements. So polypharmacy has been indicated as a causal factor in delirium. So I know we were talking about polypharmacy in the question and answer just a moment ago. And again, I wouldn't be as concerned about dementia as much as it can cause a state of delirium. So more medication does not actually mean more or better quality of life. And in fact, some of those medications can lead to polypharmacy, which can lead to some behavior issues. So definitely recommend a medication review. I is injury, pain, stress. They can all cause delirium. So a senior can have an injury like a fracture or a hairline fracture, which can go unnoticed for a long period of time because they can't effectively vocalize that they're in pain, so it goes undetected. And that severe pain can lead to lack of sleep, which can also cause delirium. So regular pain assessments should be conducted throughout a person's decline. Unfamiliar environments can cause delirium. Well, let me clarify that the environment alone doesn't cause delirium, but it certainly exacerbates the effects. So for an example, it can be common to see delirium symptoms after going to the emergency room, or even after a room transfer where the person lives or in the hospital setting. These environmental changes increase that person's stress level. And just like I stated before, increased stress can lead to states of delirium. So if you're on a case where you know a person is about to go into a very unfamiliar environment, like a ward transfer or surgery, then we like to bring in very comforting and familiar stimuli to help decrease that rate of delirium. We advise caregivers to bring in photos, memory books, favorite bedding, favorite smells, music. Think about what the person is going to see, hear, smell when they first get into that unfamiliar environment, and try to plan some ways that you can immediately orient them to their present moment. And M is for medical procedures. So again, post-operative delirium is the most common complication of surgery of older adults. That's according to the American Geriatric Society. So for any surgery, any procedure that requires anesthesia, expect delirium related symptoms. So that could be from dental cleanings to a hip replacement. We prep our caregivers on what to expect on that medical procedure. You would not, I think you would be surprised to see how little the medical personnel prep you, share, and explain to caregivers about this adverse side effect of anesthesia. Okay, so let's briefly go over medications and providers that you're going to see in dementia care. So, like Amanda said, there's no cure for dementia, but there are medications on the market to help treat some of the symptoms. And the most common medications you're going to see are the ones above. They're called Aricept, Razidine, Exelon, Namenda, and Nemzurec. That last one is actually a combination of Aricept and Namenda. And Exelon is a patch. All the rest are pill forms. Again, they do not change the course of the disease, and the memory loss continues to get worse. What I like to point out are the side effects. The side effects can be difficult to manage for neurotypical seniors, as well as people with intellectual and developmental disabilities. In particular for IDD, I would say be aware of the gastrointestinal side effects. So it causes nausea, diarrhea, constipation. Sometimes people have to get on medications to manage these side effects. And so then I'll hear staff or family members say, well, maybe because the side effects are so great, we don't even want the person on these medications. This is definitely a family decision, or the person themselves to make that decision whether they want to go through this. I've also seen people, if they are allowed to take their own medication, they self-manage. If they take the medication and then forget the next day and take the medication the next day or a week later, it prolongs these side effects because your body's not getting used to it, because it's an on-off kind of drug, which is not recommended. So just be aware of that, those issues when when the person is prescribed these medications. Now, there are new medications on the market. There's two new ones that actually attack amyloid plaque in the brain. So that protein buildup, it flushes away out of your brain. The issues are that it's an infusion. You go to a clinic to get access to the drug. It's very expensive. It has some very major side effects. Like, you cannot take this drug if you have any kind of heart condition, and they're not covered by insurance or Medicare. So often our folks with intellectual and developmental disabilities can't get access to these new market drugs. It's so important to keep all the regular doctor's appointments that you have for that individual, and the care team, becomes the person or people who are coordinating care among all those physicians. Because as the person declines more, you'll notice there's more doctor's appointments. You got to start seeing more specialists. And even though we have electric medical records now, a lot of times people get lost in the system, things fall through the cracks. So that care plan team really needs to keep connection with all of those providers. Okay, let's talk about the providers that you'll see on the interdisciplinary team in dementia care. First is going to be that PCP, that primary care physician. And then often people get referred to, it could be a neurologist or a geriatric neurologist, or sometimes they have memory, movement disorder specialists. If you live in an area that has a geriatrician or a geriatric nurse, even better. Sometimes it's a PCP or a family medicine or internal specialist doctor that has a geriatric expertise. Sometimes I've heard family call them memory care doctors, or they'll refer to themselves as that as well. Even better is a geri-psychiatrist. Maybe they have a psychiatrist on the team too. If they move to a senior living community, if they're in your agency, but you think you got to have to move them, then you're going to be talking with the ED, the executive director. The DON is their director of nursing. And then you'll be dealing with the nursing staff. So the RNs, the LPNs, the CNAs, or the direct line staff members there. You'll probably be giving information to the activities coordinator on their preferences or activities that they do. And often in the very beginning, you'll even be contacting or talking with sales and marketing. If they're in the home or if they're getting in-home services at your agency, then they'll probably be dealing with a case manager that's associated with that other agency. They have their own nursing team. Sometimes they have OT, PT, or speech therapy that either comes into the home or you're taking them to a clinic. And then fingers crossed, you got a BCBA or an RBT on the team to help manage some of those behavior and psychological symptoms. And then if the person lives at home, or I haven't seen it in ASILA or group home, but definitely if a person lives at home, then maybe the family has contacted an elder care lawyer or someone to start putting plans in place for end of life, a power of attorney, healthcare surrogate, and whatnot. Okay, let's go over a couple of statistics here. This is a graphic of the population age 65 and older from the 1900s to projected 2050. And what you see in blue is the number in millions of seniors over the age of 65. And that red line is the percentage of seniors, the percentage of people over the age of 65 per the population at that time. And what you see is we're about right here in 2024. So there's a big change from between 2010 and 2030. So we're kind of right in the middle of that surge in seniors. And this is another graphic that depicts seniors. I think this is over the age of 60. Well, I'm sorry. It shows you the time bins down in the age group at the bottom. And on the side is the percentage of the population. So 1950s is when basically the baby boomers were born. So you can see that surge in the young population. And then it kind of, you see the seniors, the baby boomers move over time. So there's two parts of this gift that I want you to draw your attention to. The first is the end of life continuum, 55 and older. You see each of those age bands increase over the last 10, 20 years and expected to increase until 2050. And then look at the excuse me, the purple square. Draw your attention to that we're having not only are people living longer, but we're also not recreating as many. The birth rate is going down over time too. So we don't have nearly as many people to take care of those aging seniors. And this is also happening with our seniors with intellectual and developmental disabilities, that they're getting older, they're living longer. And so we see they're right around 850,000 seniors over the age of 60 with an intellectual disability. And that number is going to swell to 1.4 million due again to that increasing life expectancy and the baby boomer generation. The good news is that dementia is actually not a normal part of aging. 2/3 of those age 65 and older regard their health as good or excellent. 90% of centenarians, so 90% of people who make it to the age of 100 are actually fully independent until the age of 92. So while dementia is not a normal part of aging, it is a substantial part of our growing senior population. And there are some statistics that are out there that shows that 1 in 3 people born today are going to develop dementia. So their numbers are something like 34% of women are going to develop dementia and 32% of men. So that's about 1/3 of our population that will develop dementia. So the statistics now, depending on where you live, is about 9 to 17% of our older adults have dementia, but we can expect that rates can be up to 30%. And so if we're looking at the people that we're caring for with intellectual and developmental disabilities, expect those same numbers, that they're going to at least probably about 30% of your aging population is going to show signs of a memory impairment. Okay, let's talk about some behaviors, well behaviors as well as challenging behaviors. So Our senior population are not only the oldest, but they're also the sickest and frailest population we've ever had to care for, because not only are they showing memory impairments, but they have some other comorbidities, including hypertension, congestive heart failure, diabetes, thyroid issues, a lot of skin issues, osteoporosis. And in particular, for people with intellectual disabilities, they also have an increased risk in seizure disorder. So even if they never had seizures before, their risk increases as they get older. We really like to focus on health and well-being behaviors to target, to increase when we get called into families' home, or when we get to collaborate with teams. In particular, we like to focus on nutrition and water intake. So like I mentioned earlier, we do not want the person to be in a state of delirium. They are much more difficult to manage, and very, that's a medical issue that you're dealing with. So we have to treat that medical issue. So making sure they have well-balanced meals as much as possible, getting some extra veggies in, fruits and vegetables, as well as increased water. So again, almost all of the people that we work with, we try to say, how can we get more water for them? Socialization and cognitive stimulation are quite critical in senior care. Socialization, isolation is the new smoking, according to the Surgeon General. So they have recorded that one day of no interaction with people, or limited interaction with people, is like smoking 15 cigarettes a day. And we don't want our individuals, especially our seniors with intellectual disabilities, smoking that much. So we want to make sure that we're engaging with them, socializing with them, getting them out as much as possible. Out meaning outside, out and about in their house, just kind of moving around, which leads me to movement is another behavior that we like to target. So if they move a lot, great. Make your steps goal 10,000 per day. But usually it's more like 7,000. Maybe it's 2,000 steps a day. Maybe we're just working on 500 steps to get them moving. That's okay. We're meeting the person where they are and making goals for them there. Decluttered environment, that's something we target if we're going into a family's house. Most of the time, if we're going into an agency, SILA or group home, this is well taken care of. And then I just want to throw this out there, that if you haven't looked at dimensions of wellness, so there's 6, 7, or 8 dimensions. We like to use the 8 dimensions of wellness. We like to include that in our activity engagement, how to increase activities. We focus on each of these domains. We look at what they're doing now, what they would like to do, and make goals to try to increase that. Now, I will say that caregivers, family members, they can accept memory issues when it comes to dementia. Like, I can't remember your name, or I'm getting lost in a conversation, or I couldn't remember I had a doctor's appointment today. What they have a difficult time tolerating is behavior and psychological symptoms of dementia, i.e. challenging behaviors, also called NPS, neuropsychiatric symptoms. And they look very much like the challenging behavior symptomology we see in the IDD population: agitation, hallucinations, irritability, disinhibition, walking around, wandering, eating problems, sleeping problems. This is not new to the field. I think what is new to people, or what is shocking to family members, is that I never thought this person would engage in X behavior. That's kind of what's more surprising to family and staff members. They have the same kind of side effects. Okay, if a person is engaging in BPSD, behavior and psychological symptoms of dementia, increased risk of isolation, institutionalization, they're put on more medications. They actually decline faster than people who don't have as many or as difficult challenging behaviors. It includes risk of restraint, chemical restraint, and physical restraint, increases healthcare costs. The thing about challenging behaviors is that it happens at 95, I would say 100%, but the literature says 95% of people who have a diagnosis of dementia are going to get a challenging behavior. It doesn't matter what stage you're in, what the etiology is. That means the type of dementia, So Alzheimer's, vascular, mixed, frontotemporal, Parkinson's related, they're all going to get some type of challenging behavior. And honestly, right now, what we see is that it kind of fluctuates in the topography. So what it looks like, severity, and frequency. The most common approach is that we take them to a doctor, they get prescribed antidepressant and anti-anxiety. All too often, I think antipsychotics are given. All of these medications are off-label because there is absolutely no medication on the market to manage behavior and psychological symptoms of dementia. And in fact, each of them come with their list of side effects that we have to be aware of, especially in those who are a bit more fragile and vulnerable, like the IDD population. And on some of them, they have a black box warning. On antipsychotics, there's a black box warning that says if you take this and you have dementia, you're actually at an increased risk of death. Most people don't want to take these medications. Families don't want to give these medications. Providers don't want to prescribe these medications, but there's not a lot for people to do. So we really encourage people to look at dementia from a behavior perspective. If we can look at behavior in the context in which it occurs, look at those antecedents, those consequences, those motivators, not just of today, but what motivated the person 2 years ago, 5 years ago, 20 years ago, because remember, this is a long memory issue. And as they decline more, they actually you lose the short-term memory, but you have the long-term memory. So what motivated them in their 20s? Let's bring that back into the context, because we really believe that if we can modify the environment, modify the context, well, then BPSD, behavior and psychological symptoms, they can be changeable and they can be preventable. Okay, I want to dip into, I see we're at 11:11. So I'm going to do some end of life issues, and then I'm going to try to leave us some time to get to some more questions. The first thing that comes up, especially in the IDD population, but in the neurotypical population too, is the idea of feeding tubes, especially in late stage Alzheimer's or late stage dementia. Let me say, there is no literature, there is no evidence on the market that feeding tubes, they do not add to quality of life. They do not extend a person's life. So oftentimes family members or staff members are asked at a very crucial and vulnerable time period in a person's life, do they want to put them on a feeding tube? And that could be gut-wrenching, heart-wrenching, because you think, I want to do what's best for this person. And, I don't want to get too much into it, but healthcare is a business, okay? The more procedures we do, the more it's a commercial business and they make more money off of that individual. So if you know that that an agency or a provider is asking this person to have a new procedure, a feeding tube, but there's no data, there's no literature that it extends quality of life or it extends their life at all, in end-stage dementia, just consider that when you're making your decision. And sometimes I like to tell families so that it makes them feel better, because if they want to say no to a procedure, but they just feel guilty that they're saying no, this helps them to where they don't feel as guilty, because at least they're making a decision based on some data and some research. Okay, so in terms of service planning for a person's end of life, definitely in the mild and moderate stages, we like to do a lot of independence work with that person, self-care work. We like to do self-management. Can they self-score? How can they self-regulate? A lot of work with the person one-on-one. Once they get into that severe stage or late stage, it's less about one-on-one with that person and it's more about caregiver training, because it really ultimately, the person's going to require more 24-hour care in their end-of-life care. Just to touch upon advanced care plans, if you don't have advanced care plans for your seniors, I would definitely start thinking about that and planning, what can I do to put more advanced care plans into the annual assessment. So that could be things like, who's going to take over their health and financial decision making? So if they're their own power of attorney, they make their own they're their own guardian, right? Well, you want to make a plan in place before that person has a diagnosis of dementia, because then it gets kind of complicated because they might be deemed incompetent to make their own decisions on who's going to be their power of attorney or guardian, or there's even something called a healthcare surrogate. Anyway, so start thinking in terms of who's going to be on that person's care plan team. Also consider their celebration of life. People with intellectual disabilities have the right to die and to be celebrated as they wish. All too often, I think caregivers don't want to discuss mortality with our clients because it translates into them thinking about their own mortality. And, that could be an emotional time period for our caregivers. But I really believe that we all deserve to be celebrated as we wish to be. So, what colors do they want at their celebration of life? What readings do they want? What music? Who do they want speaking? What food? Where do they want the ceremony? What do they want to do with their bodies, as in burial, cremated, made into stones? So please encourage your team and your staff to start thinking about how do we want to celebrate them after they pass. Okay, let's quickly touch upon where is a person going to live in their later stages of dementia care. So if you are a neurotypical senior who has dementia, you have a lot of choices on where you can live. Independent living in your home, and get services brought to your home, assisted living, nursing home, dementia care units. For people with intellectual disabilities, honestly, you don't have a lot of choices. You have two main choices, I think. One is that we put them into nursing homes. Often they're like dementia care units, wings of a nursing home, or which we advocate for is the one on the bottom, stay at home for as long as possible. Bring in interventions, education, training, home modifications to keep those seniors there for as long as possible. There's a really great program called the GRACE Project in Illinois. GRACE stands for Generating Resources for Aging Through Collaborative Efforts. It's a whole manual. I think it's a 40-hour training for direct line staff that goes over residential services, aging in place, Alzheimer's and dementia, health promotion. You can find more information at intersectforability.com. And the third option that I think is growing, but I would like to see it grow faster, is dementia group homes for intellectual and developmental disabilities. So honestly, there's two different ways. There's a continuum of houses. I think that's a little bit tricky because the continuum of decline doesn't look so progressive, because the person can have a fall, and so in their mild stages, and that sends them straight to a severe impairment. Anyway, we would like people to consider more single dementia care homes for all levels of dementia, so whether they're in the mild, moderate, or later stages of the disease, and you have dedicated staff who are trained in dementia care specifically. And then we wanted to mention hospice. We think that hospice isn't called in soon enough or often enough, especially for our IDD population. I like to think of hospice, or just give them a call for a consult. Consults are free. And I like to call them in when I hear staff or the person themselves say, I do not want to keep going back to the hospital. So for those people who are having strokes or mini strokes, we make a care plan in place where we're not taking them to the hospital every time. We're consulting with hospice and we're trying to keep them home. Or if a client or the caregiver says, I don't want to live like this, or if there is a terminal illness like end stage renal failure, some stages of cancer. Dementia is not a terminal illness. Advanced dementia, end-stage dementia, you are more likely to get access to hospice, but you have to have some other criteria. The reason why I love hospice is not only do they help manage that medication list, get people off of as many medications, they bring in free medical equipment, free, taxpayers are paying for that, but hospital beds, chairs, walkers, those air mattresses that you put on the bed so the person doesn't get a pressure sore. They provide respite care. They come in and do feedings or showers. So what I love about that for a group home is that you might have one staff and 5 people. And if one person has dementia, well, that's going to be really difficult for that one staff to manage in that care home. So especially giving some of the ADLs like feeding and shower. So hospice will come in and give a shower to that person. So it frees up that caregiver and they can attend to other people who are living in the house. They have inpatient care units. They provide the routine care, like I said. And what I love, love, love is that they have bereavement support. So they come in and help not just family members, but staff members. You know, we as staff members really build a connection to the people that we serve. And so when they have dementia or when they pass away, you know, there's a real loss that our caregivers go through. And we need to give them the supports that they deserve, the emotional and spiritual supports, wellness that they deserve. And the chaplains, the bereavement support that hospice has is just, they go above and beyond. I just can't sing their praises enough. In dementia care, it's all about planning for decline. You're going to change their goals of care more often than you have changed their goals of care in the past. You're looking at medical decisions. If they're in the home, even if they're out of the home, there's going to be family dynamics that are happening that has never happened to this family before. Their relationships are going to change over time. You know, you have mamas who were taking care of kids and now their kids are taking care of the mamas. And that's an emotional and spiritual thing that the family members have to adjust to as well. It is about an enriched life. End of life is about quality of life. It's not about how long can we get that person to live for, how many days. It's more about how we can make each day more special. So it really is this balancing act. You know, honestly, it goes up and down, back and forth between the caregiver and the care recipient. And it's an ongoing conversation. You know, if there's any change in health, cognition, if there's a fall, if there's a medical event that happens, a person is physically unable anymore, oh, it really changes the cogs in each aspect of the person's life. So continue to coordinate, communicate, and collaborate on your team, especially in dementia care. This is the national task group that Amanda had mentioned earlier. They have their own, the EDSD, so the early detection screening tool. Excuse me. And they actually, it's a whole website. There's guidelines for supporting people with intellectual disabilities and dementia. It is a wealth of information. Definitely check them out at the-ntg.org. That has been our toolkit. And now I'm going to stop talking and take some questions.
All right. Let's see. You have quite a few questions still.
Okay,
So,
wonderful.
let's see. Uh, does plaque development affect neuroplasticity, or is that more to do with normal aging?
Absolutely, it does. And that's exactly what Amanda was referring to in that neuroplasticity just means basically like how well your neurons kind of communicate to each other. So we might hear this in terms of a stroke. So a person loses their right side, their ability. And so in physical therapy and occupational therapy, and you know, what's happening is that their neuroplasticity is changing. We're teaching them how to use their left side more, for example. So you're teaching them like an alternative way to do a task. Well, if the neurons, if the plaque is building up over time, and say the person is less educated, and so they only have one way of doing a task, and that protein has built up, well, you're going to see that tasks decline or go away over time. So if we could teach them a new way to do that same task, build that neuroplasticity, then we can see maybe increases in that ADL or that task. But yes, all those kind of go together.
Can you speak a little bit about Alzheimer's and dementia? There's a little bit of confusion because we've had some people ask, like, how can you rule out Alzheimer's considering the symptoms are the same? We had another attendee talk about how, previously Alzheimer's was diagnosed through autopsy. Is that still the case? So if you could just speak a little bit about Alzheimer's and dementia.
You want to take that, Amanda?
Sure. So the first question about dementia versus Alzheimer's disease, that's dementia is the umbrella term, right? So it's just kind of like that big overarching. So any other of those 70 to 90 types of dementia, that's all under that dementia umbrella term. And then Alzheimer's disease is just one specific kind. So you wouldn't be like picking between dementia and Alzheimer's disease. Dementia is just the less specific term. Sometimes when we're not sure because of the difficulty, as you mentioned, in diagnosis or the question asked, and you might just get a general dementia diagnosis. In terms of diagnosis with autopsy, that is absolutely, honestly, probably most often still how people are diagnosed, and that we're relying heavily still on those cognitive screening tools. But all the time, I mean, even since Miranda and I have been practicing, there's constantly new scans and research, and I don't think you talked about it today, Miranda, but some of just additional research and ways to determine, what's going on in a person's body. I'm sure you have more to say, Miranda.
Yeah, absolutely. I guess just want to speak specifically to the IDD population. It is really hard to get a differential diagnosis in this population because, like Amanda said, we're using the least scientific ways to determine dementia. So that's why we like to use dementia, especially in the IDD population, because they're either going to get honestly, it's like a diagnosis of dementia or not. It's not like they're going to say, oh, this is of the Alzheimer's type or this is of the vascular dementia type, because, then you would have to get like fMRI screenings done or a neurocognitive assessment done. And I have just never seen Medicare or Medicaid reimburse for those services or just allow for those services. It's more like, we do these assessment. It comes from the PCP. So either you go in, you see the PCP and they diagnose in that one session without really knowing the person, or you come as a member of the team that has several years of baseline data and you're trying to rule out any other medical condition. It gets really difficult in the IDD population, mainly because they don't have access to the things that neurotypical seniors have access to. So I think that's probably where the confusion comes in. Why are we talking about Alzheimer's here and dementia there? It really depends on the population that we're serving, to be quite honest.
Charlotte just asked the question. So if you have Alzheimer's disease, then you definitely have dementia, but not
Yes.
the other way around. So,
correct.
Sorry, just clarifying, because dementia is the umbrella, and then
Yes.
Alzheimer's is a type. Sorry, just
That's right.
clarifying.
Thanks, Amanda.
And to go along with what you were saying about screening and doctors, so we've had a lot of questions about, like, how do you handle if a doctor's unwilling to screen someone? And on the flip side, how do you handle an individual who is aggressive and opposed to getting any sort of testing?
So these actually sound like two different kinds of people. I guess I'm just guessing. So if it's in the IDDD population, I hear it all the time. Like, I can't touch that. They have an intellectual disability. I have no idea if they have dementia.
Yeah.
So that's really where we rely heavily on ruling out all those medical rule outs and then getting that documentation. I've also had teams take specific data on the OBCs. So if a doctor were to say, well, that actually sounds like bipolar or schizophrenia or depression, I'll say, okay. So then I'll have the staff take interval data, specific data on those psychiatric diagnoses, those criteria, to help us rule out. And so then I'll say, like, okay, well, we do have some symptoms of depression because those actually overlap a lot with dementia. And then we'll try an SSRI. We'll try a couple of the antidepressants. And if we see no effect on other things, then we're going to know it probably wasn't depression. So sometimes this is kind of it's a long road. It's not something like as quick and definitive as yes or no. Sometimes
Mhm.
it's, okay, we rule out all the medical. We know it's not UTI, we're making sure it's not psychiatric. And then we go to, okay, we've done all of our questionnaires, and then we go back to the doctor and say, hey, it can't be anything else other than dementia. And then usually by then they're willing to diagnose. But then honestly, in some cases, I just recently had a case that, the doctor still wouldn't diagnose, but we treated as if she did have dementia, that we had ruled everything else out. And so now she's not on a medication, like a memory medication, but we provided some environmental arrangements and different interaction styles and skillful prompting, and changed, worked with the staff on their caregiver expectations. So then that way we were providing that dementia, proactive service, even without, because it can't really hurt them, right? It's only going to be more thoughtful and proactive and loving. So it was still okay, even without that specific diagnosis.
Brava.
Let's see. Is it usual for someone to have an official dementia diagnosis and then fluctuate up and down with their decline over the years? Like
Yes,
they get better and
absolutely.
worse on and off with med changes?
Med changes, the environment, you don't even realize the micro antecedents that can affect someone's behaviors. So we think that, oh, nothing has changed, but we don't really know from their perspective what has changed. So in dementia, there's moments of lucidity and then moments of very foggy, like I can't remember anything. So there's so much to Alzheimer's and dementia in general that we just don't know about, that researchers are only now getting chances to look into it. So I do think over the next 10, 20 years, we're going to find out so much more about it. But right now it's limited information. But yes, it's going to be a lot of fluctuations.
And even just think of, like, if they didn't sleep well the night
Oh,
before, that
so
could
right.
influence if,
Yes,
if they're not eating, or they
that's
just haven't
right.
eaten today, or I
Yeah.
mean, just so many different smaller things that we, kind of just wouldn't say are such
Yes.
big context clues, are probably contributing to more confusion that day.
That's right. Stomach ache, headache. That's why, managing that water intake and nutrition are one of our top two things. Like make
Yeah.
sure that we're good on that so we can rule out that they're not having these internal issues that they can't express and we can't see.
Just a couple more, and then if people have additional questions, they can reach out to me and I can get those answers for them. Just for the sake of time, I know obviously
Absolutely.
everyone's busy. You guys have things you need to do to get on with your day. But a lot of people have asked, what is an appropriate age to start doing these screenings at the annual and semi-annual meetings?
So for Down syndrome in their 40s, and then for everything else in their 50s.
Mhm. I mean, really, the earlier the better, honestly, because you just have more baseline data. And once you start doing these tests, you'll realize that it doesn't take that long to do, to even just add in a line item on their annual assessment that says, okay, here's what they're scoring on their ABDQ, because the ABDQ does give a number.
And then the last question we'll take, like I said, if you have additional questions, please feel free to reach out to me and I can make sure that those questions are answered just because we are out of time. But Kelly asks, is the importance of obtaining a diagnosis for additional programming and insurance benefits?
Um, I guess, this question comes up about insurance, and I don't know if for people with intellectual disabilities, I don't know if there's really any change, nothing different, right, Amanda, is happening whether they have a diagnosis or not with their insurance. If they're Medicaid or Medicare and they've been that way all their life, there's really nothing different. Now, if they have other health care, like if they don't have IDD and you have a retirement plan kind of insurance, well, that insurance is going to cover only what Medicare covers anyway. So if Medicare doesn't cover something, then that retiree benefit is not going to cover it. Besides, let me say, a couple drugs, the infusion drugs that I talked about for the amyloid plaque, and there is a new assessment on the market that's a spinal tap for Alzheimer's disease in particular. Your insurance will cover one test in your one lifetime. And so usually people will get it when they're trying to differentially diagnose the person after screenings, after a battery of tests. That test is not covered by Medicare. So our people with intellectual disabilities do not get access to this cutting edge assessment that we have on the market. But I don't know of anything special about insurance besides, can they get access to can they get access to hospice, because hospice is a Medicare program and they're already on Medicare. So I've heard some people say, oh, that's kind of like you're double dipping. Although I also know agencies that have used hospice care. So other than that, I really don't see any difference with a dementia diagnosis in their insurance planning.
Yeah.
And we, like Scott had said in the chat box, a diagnosis really opens up a new source of community support and
Yes.
resources in that sense.
Yes, thank you, Scott. That is absolutely correct.
All right. Well, thank you, ladies, so much. Everyone is very appreciative of the information that you have provided today, and we
Wonderful.
appreciate you spending your time sharing your knowledge with us. So thank you so much.
Thanks for the invite. Happy to do it.
Thank you.
And thank you, everyone else, for joining us today.
Yes. Oh, I love all the hearts. Okay.
Have a good rest of your day.
All right. Bye-bye.